Good morning. My name is Jason Hansen, and I'm a student at Kaiser University in the Bachelor's of Interdisciplinary Studies program. And this is my video project on the anterior cruciate ligament and its injuries. Today we're going to briefly discuss the ACL by covering the anatomy of the area, how to recognize injuries, tests and assessments, general rehab protocols, and prevention strategies. But first, I would like to give you a brief orientation of the ACL and the knee joint by showing a quick video and describing the ACL and its key functions.
The anterior cruciate ligament, or ACL, is an important structure found deep within the knee joint. As we see here, the ACL is a ligament that connects two bones, the thigh bone, or femur, and the shin bone, or tibia. The ACL is made primarily of type 1 collagen, a substance that is found in soft tissues and bones throughout the body. And even though it looks small, it can withstand forces of up to 500 pounds. The ACL's main function is to provide the knee with stability. It does this in two ways. First, it helps keep the tibia from moving too far forward on the femur, or over-translating. Second, it keeps the knee stable during rotation. Think of it kind of like the cables on a suspension bridge. It connects the thigh and shin bones, helping to keep them in place and provide support for the knee in moments of stress. There are two distinct bundles that make up the ACL, the anteromedial and the posterolateral. Each gets its name from where it inserts on the tibial surface, here and here. Together, these two bundles help provide stability for the knee throughout its complete range of motion. To be specific, the posterolateral bundle is more protective when the knee is extended, like this. And as you might have guessed, the anteromedial bundle is tighter when the knee flexes, like this. For more specific...
Next, I'd like to talk about mechanisms of injury for the anterior cruciate ligament. The Mayo Clinic defines ACL injuries most commonly occurring during sports that involve sudden stopping or changing in direction, jumping and landing, such as soccer, basketball, football, volleyball, and downhill skiing. ACL injuries often occur when there's dynamic knee valgus, external rotation of the tibia, internal rotation of hip, or any combination thereof. Next, I'd like to show you a video of NFL wideout receiver Julian Edelman sustain a non-contact ACL rupture. During the video, be sure to check out the forces that were applied to the joints that led to the rupture. We're going to go ahead and talk about recognition of ACL injuries. So if you think that you may have sustained an ACL injury, there are a number of tests that can be performed to confirm an injury to the ACL. There's the Lockman's test, a pivot shift test, drawer test, and the lever sign. Today I'm only going to briefly discuss the lever sign for positive ACL ruptures. Now remember, all ACL injuries should be evaluated by medical personnel. First, we're going to talk about a negative lever sign. When looking at example A, you will place your fist underneath the calf, acting as a fulcrum, with the second hand pushing down on the quadriceps. A negative lever sign will cause the ACL to counteract the downward force applied to the quadriceps, elevating the lower leg. Now let's talk about a positive lever sign. If you're looking at the slide, you will see example B. Again, when pressure is placed on the quadricep, as shown, the lower leg will not elevate because the ACL is unable to counteract the forces applied to the quadriceps, and the lower extremity will demonstrate extensor lag and will not elevate. This is a positive sign for an ACL rupture. Okay, next thing we're going to talk about. We're going to talk about the initial treatments of an ACL injury in the acute phase from 24 to 72 hours, and we're also going to talk about available treatment options for a ruptured ACL. First, we're going to go ahead and talk about the initial treatment of the ACL injury, 24 to 72 hours post-injury. First things, you're going to want to avoid all activities utilizing the affected knee. Then you're going to avoid weight bearing on the injured leg, use crutches as needed, apply Rice principles, rest and avoid activities, ice the affected area during the acute phase of the injury, use compression on the affected knee, elevate the knee higher than the heart, and use non-steroidal anti-inflammatory drugs for inflammation and pain. Then you're going to want to seek a medical evaluation from your provider to confirm ACL injuries and consultation for further treatment or surgical protocols. Next, let's move into treatment options. Now, when sustaining an ACL injury, you're going to have a couple of treatment options. You can decide to elect surgery, or you can decide not to elect surgery, but there are some criteria that go with both. Now, decisions on whether or not to elect surgery for an ACL rupture are based on three criteria: the age of the patient, their current activity level, and the presence of arthritis. If your sports days are behind you, or you have arthritis of the knee, you may want to forego surgery and elect physical therapy to manage the injury. For those who meet criteria for surgical repair, there are two procedures to repair the ruptured ACL. They are ACL autograft repair and ACL allograft repair. Now, talking about non-surgical approaches, again, these are normally reserved for the weekend warriors, for those patients who do not plan to be physically active and they are no longer participating in sports. Now, post-recovery, the patient may or may not feel any pain, but they will continue to be prone to frequent episodes of instability and development of other ligament injuries surrounding the knee joint for the rest of their lives. Now, when we're talking about a surgical approach, there are two approaches. Again, the ACL autograft. This is where the surgeon will normally harvest the semitendinosus or the gracilis tendons of the patient and surgically fashion and replace the tendon back in the knee joint. The next one is the ACL with allograft. This is where the surgeon will harvest the tendons from a cadaver and then again will fashion and replace the ACL tendon in the knee joint. Now that we've discussed initial treatment protocols, we're going to move forward and we're going to discuss post-operation treatment protocols. These are the therapy protocols that are going to be in place, and they're conducted in 4 phases post-op with an ACL allograft repair. The first phase is going to be from post-operation through the first 6 weeks, with focus on protecting the surgical graft, controlling inflammation, getting full range of motion of the knee in extension, flexion of the knee to 90 degrees, and to restore weight bearing as tolerated. In the second phase, we're looking at 6 to 8 weeks with a focus on initiating closed kinetic chain exercises, restoring a normal gait pattern, protecting the graft fixation site, and, if possible, discontinue the brace and crutches when full extension is attained and you can achieve a straight leg raise without any extensor lag. Next, moving on to phase 3. This is going to be 8 weeks to 6 months post-op with focus on a full pain-free range of motion, no evidence of patellofemoral joint irritation, strength and proprioception at approximately 70% of full strength, continue to progress strength, power, and proprioception as tolerated. Phase 4. This is going to occur between 6 and 9 months with focus on progression of flexibility and strengthening, a walk-jog progression, forward and backwards running at varied speed, progression of strength, power, and proprioception to prepare for return to functional activities. And phase 5 is going to be 9 months plus with focus on initiating cutting and jumping activities, complete all functional progressions as indicated in the plan of care, maintain strength, endurance, and proprioception, and most importantly, educate the patient on his or her post-therapy limitation. Lastly, we're going to discuss prevention strategies to prevent future ACL injuries and prepare the knee joint for increased activity. First thing that you want to do is you want to do a warm-up. This is critical for all activities. A warm-up is a group of exercises that are very basic and they're very functional, sport-specific movements. This is normally done for about 5 to 10 minutes and could be as easy as a brisk walk or a light jog. Next, you're going to go ahead and start with some flexibility, stretching the muscles that control the flexion and extension of the knee. This is done through a dynamic warm-up or static stretching. Dynamic warm-ups are usually done in the warm-up portion. Those are exercises that prepare the body for movement. And then you have the static stretching or flexibility, which is done post-workout. And that is where you're going to stretch and hold a position for 30 to 60 seconds for 3 to 4 sets. Then there's strengthening. We're going to obviously have to build up the muscles around the knee. We're going to use proper technique, which will lead to better stability in the knee joint. Some of those exercises are straight leg raises, quad sets, squats, and terminal knee extension. Next, moving further on and higher level functioning, you have plyometrics. This is a technique and it's all about the landing. Each movement will launch you off the ground and attempt to land softly, which will prepare your ACL for various sport-specific movements. And lastly, we have agility. This again will be customized for each individual athlete and their sport. The focus will be on knee extension, hip position, foot contact, control, and stability with each movement and activity. Now that we've discussed initial treatment protocols, we're going to move forward and we're going to discuss post-operation treatment protocols. These are the therapy protocols that are going to be in place and they're conducted in 4 phases post-op with an ACL allograft repair. The first phase is going to be from post-operation through the first 6 weeks, with focus on protecting the surgical graft, controlling inflammation, getting full range of motion of the knee in extension, flexion of the knee to 90 degrees, and to restore weight bearing as tolerated. In the second phase, we're looking at 6 to 8 weeks with a focus on initiating closed kinetic chain exercises, restoring a normal gait pattern, protecting the graft fixation site, and, if possible, discontinue the brace and crutches when full extension is attained and you can achieve a straight leg raise without any extensor lag. Next, moving on to phase 3. This is going to be 8 weeks to 6 months post-op with focus on a full pain-free range of motion, no evidence of patellofemoral joint irritation, strength and proprioception at approximately 70% of full strength, continue to progress strength, power, and proprioception as tolerated. Phase 4. This is going to occur between 6 and 9 months with focus on progression of flexibility and strengthening, a walk-jog progression, forward and backwards running at varied speed, progression of strength, power, and proprioception to prepare for return to functional activities. And phase 5 is going to be 9 months plus with focus on initiating cutting and jumping activities, complete all functional progressions as indicated in the plan of care, maintain strength, endurance, and proprioception, and most importantly, educate the patient on his or her post-therapy limitation. In closing, we have discussed the anatomy of the ACL and the knee joint, the description and recognition of the injuries, initial treatments and rehab protocols, tests and assessments, and prevention strategies. At this time, if I have no further questions, this concludes my presentation. Have a great day.